Good evening, everyone. Just want to thank everyone for joining us tonight. I'm excited to talk about one of my favorite products from New Smile, and that's their Zirconia crowns. Anyway, some background about myself. I've been married for 16 years. I got two beautiful children, Tom and Mila. We're based out of Amarillo, Texas. I'm a partner in a multi-specialty, multi-office group. We have 5 locations in the Panhandle, a Triple HC ambulatory surgical center, 7 pediatric dentists, 1 full-time orthodontist, 2 part-time orthodontists, an oral surgeon, and then these are my 2 partners, Dr. Mike Ross and Dr. Devin Cooper. I got a bachelor's and master's in neuroscience at Tulane, took the MCAT, got into medical school. Hurricane Katrina happened, kind of changed my plans. Wanted to stick around New Orleans, so I started teaching middle school math and English in Marrero, Louisiana. Somehow found my way into dentistry. I went to Texas A&M University School of Dentistry, and then I went to Children's National Medical Center, DC for my residency. And let's see, this a little background on my experience. I've been offering zirconia crowns in our office for the past 9 years. I did mostly strip crowns and some porcelain fused metal crowns in residency. Also did some in private practice. But unlike residency, with more follow-up, I realized that there had to be a better option for that was more efficient, longer lasting, better aesthetics. So I signed up for a couple different workshops with different companies, and I kind of started my journey with zirconia crowns. And about 9 years later, I do a lot of these in the clinic with nitrous. I do a lot of these under general anesthesia in our surgery center on the daily. And I've probably placed about 5,000 to 6,000 over the last 9 years. I've used a lot of different companies out there, and ultimately, after trying them all out, I've been the most satisfied with New Smile. Disclosure, New Smile has provided financial support for this presentation and materials for the practical training of pediatric dentistry. Some of these images were taken by fellow New Smile clinicians and are credited. Real quick, this is everything we are all very comfortable with here. Just the AAPD guidelines on full coverage restorations and when they're needed. Probably won't go through any of this. This should be very familiar with everyone in this presentation. Types of full coverage crowns. Again, my background is in strip crowns, porcelain fused metal crowns prior to my switch to zirconia crowns. I know everyone here is probably familiar with a combination of these. Anyway, so zirconia crowns, here's an example from Dr. Matt Lucero, immediate post-op in a GA setting, very aesthetic results, minimal damage to the gingiva, looks very nice. Good example. Anyway, so monolithic zirconia primary crowns, some of the advantages, they got the best aesthetics. They have great soft tissue compatibility. There's no metal show. They're durable. They're great for anterior crossbite cases. I've used them on anterior crossbite cases, and I've had good results. I've had no issues with that, which is nice. There's no nickel. There's full cover protection, and there is minimal chair time with practice. When you're first kind of starting out with these, I'd really recommend being thoughtful of your case selection. Avoid cases with crowding, avoid cases with space loss. I'd probably, wouldn't do any cases with pulpal involvement, and obviously, choose patients with good behavior. Learn the prep, learn the fit of the crowns before attempting more difficult cases. I don't think any of these, even with time and becoming expert at it, you'll never be able to do it as fast as you would as an SSC in the posterior. However, you can be as confident as you are when you recommend an SSC as you will to recommend a zirconia crown to a patient. So I offer these to every single patient for the most part, and I really let the parent kind of make the decision, but I do set expectations, and we'll talk a little bit more about that later. They're autoclavable. They can cause color change over time. I haven't personally noticed a change, but if you're having to do it a lot when you're first learning the sizes, that could be the case. No artifact and imaging for special healthcare needs patients. Disadvantages, obviously you cannot crimp these you need a true passive fit of the crown. That's why learning to master the preparation is vital, and experience is very important. Saliva and hemorrhage must be controlled. We'll kind of talk more about options for that. Learning curve, there's obviously a learning curve here. And the cost. I personally don't think the cost is a big disadvantage, because once you learn how to do these well, you seat them properly, they will last until that tooth falls out naturally. And it's as opposed to doing like a class 3 composite restoration with minimal retention that falls out and you got to replace it. And this has made me, made our patients and parents more satisfied, and especially me as a clinician. Let's see the new smile scribing. So there are notations on the back of these crowns. You really can't see them. I leave them on personally, but it's also, you can remove them if you think that's an issue. What is the relevance of gloss on zirconia surfaces? So key points here, new smile crowns are highly polished, which results in less plaque buildup, easier cleaning, better aesthetics, and creates less abrasion and attrition on the opposing teeth, as opposed to crowns that are hand glazed. There are a lot of the other brands out there do hand glazing, which can cause inconsistencies. Zirconia's high biocompatibility, confirmed by numerous studies, makes it an ideal material due to its minimally adverse tissue reactions. Here's a perfect example. You can see how well the tissue's responding to that. It almost looks like a natural tooth. It's responding so well. Again, these highly polished zirconia crowns, zirconia ceramics are chemically inert. They're biocompatible. They promote good cell adhesion. They prevent plaque buildup, and no reported adverse systemic reactions. So a couple studies kind of reviewing the strength of zirconia crowns. Studies show that zirconia exhibits significantly superior flexural strength compared to natural tooth enamel, making it highly durable for restorations, but potentially more abrasive to opposing natural teeth if not properly polished. That's why nice new smile puts so much emphasis on a highly polished finish. Another study here showing, before and after cyclic fatigue testing, new smile crowns maintain a maximum fatigue load well over the maximum biting force of a child, just more support to their strength. And another study here, basically this study just showed that a new smile zirconia crowns opposing natural primary enamel maintained a normal wear rate equivalent to natural primary enamel against other natural primary enamel. So just more cases kind of supporting the evidence that these are great options for our patients. That last test used something called a Linfelder testing instrument. It's also known as an Alabama Wear Simulator. That's great. Okay. Anyways, so new smile uses a patented injection molding technique. We'll kind of go into that a little bit and kind of describe why having a molded crown is superior to a milled crown. When comparing injection molding and milling as manufacturing techniques for dental crowns, injection molding offers several distinct advantages that enhance precision, efficiency, and clinical outcomes. For instance, injection molding achieves thinner cervical margins that comes out to about 0.2 millimeters, which promotes better gingival adaptation and aesthetics compared to the thicker 0.5 millimeter margins typically in milled crowns, which can compromise the fit and increase the risk of plaque accumulation. Additionally, injection molding ensures exact uniformity across all parts, facilitating reliable trying crowns and consistent results. Whereas millings suffers from burr wear that makes controlling uniformity challenging, potentially leading to variability and rework. While milling allows for easier changes to shapes and features during production, injecting molding minimizes material waste and is more cost-effective overall, making it a superior choice for high volume, precise restorations without sacrificing quality. And And I believe that's why New Smile went with the molding crown technique. Again, there are a lot of other crowns on the market that are milled. Let's see now, kind of talking about the internal surface of these crowns. New Smile utilizes an internal surface treatment that mimics sandblasting to maximize the surface area, which will enhance the mechanical retention for stronger bonding without compromising the crown's structural integrity, thus improving durability and clinical performance in pediatric restorations. This is just comparing the marginal thickness of different brands. Thinner is better. You're going to get better gingival adaptation and aesthetics. Another great visual representation, just showing that marginal adaptation. That New Smile crown is all the way to the left there. Here's an example from Dr. Jorge Cassian showing the same tooth, but with different crowns. You can see that significant difference due to the marginal adaptation from the uniform thin tapered margins of the New Smile. So adapting much better, looks better, tissue's happier, it's not as thick, so things are fitting well, just a much better result. You can see that right there. And then another great visual representation from an extracted tooth. You can just see how well those cervical margins are adapting to the crown of that tooth. Another great feature with the New Smile is they have this try-in system, which is great when you're first learning how to use these crowns. Basically, it uses reusable autoclavable pink replicas of that are identical to the final restoration, which in your benefit eliminates saliva and blood contamination risks that compromise the cementation. So it helps ensure superior bond strength, it simplifies the procedure, and it's long lasting, resulting in aesthetic results every time. So these are great when you're first learning to size the crowns. I do not use this anymore personally. Luckily, I can eye it for the most part and usually get it correct, or if not, within one size. But at the beginning, I wish I had this because it would have been a lot less autoclaving, a lot less crowns that we were wasting, and it would have helped with keeping things not contaminated. So great option when you're first learning these. Oh, and another great benefit, these are $8 as opposed to $27.50. So if you're going to ruin a crown, ruin the trying ones. Let's see. And then, there's this product also known as IvaClean. You can keep one in each op if you want. Basically, it effectively cleans the zirconia restorations by removing contaminants like saliva and blood, which obviously will help with bond strength and long-term success. Again, a product I would have loved to use when I was first learning how to use these crowns. I was not familiar with it, but it would be a great tool to have while you're still learning how to become efficient with these. And yeah, here's a great visual representation of the trying crowns. This is not a personal case, but it just shows how you trying these on, making sure they fit well, and they mimic the final ones. I do think on tooth E, I think that crown is getting hung up on F a little bit. If I was doing this case, I probably would have reduced a little bit on the mesial of the crown of F to give you a little more space for that E to sit fully down. The nice thing about these zirconia crowns is they are a little forgiving. You can reduce a little bit of the crown itself if you need a little bit more space, if you're having trouble getting the fit down. And then as far as cementation, there's no wrong answer here. There's plenty of great options. It's really just finding out what works best for you and gets you the best results in clinical success rates. I personally use the BioSim. Here's the different types of cement. It's also showing their retention values. Personally, I used to use Activa, which is also a bioactive resin cement, so very similar. But I did recently switch to the BioSim. It's got great bond strength. It surpasses glass ionomer. It matches a resin modified glass ionomer and or a resin cement. So this is the choice that we recommend. Like I said, I also like Activa. That's the product I was using before. I like it because I like this cement one crown at a time, especially when you're doing D, E, F, and G. So you have full control of where that crown's going to end up. And these are all light cure, which is great. So hold it with finger pressure. You'll light cure it. We'll show some examples later and talk a little bit more about it, but I think this gives you the best, most predictable results. Yeah, so here are the steps here. So yeah, I'll have my assistant fill up the crown once I know the correct size. I'm going to hold it from the incisal, get it positioned exactly where I want it. I'll then have my assistant do a full cure from the facial. As soon as she finishes that full cure on the facial, she'll go to the lingual. While she's curing the lingual, doing a full cure, I'll use an explorer to remove that cement collar off the front. I like to fill my crowns all the way to the top. I like to be there a lot of excess cement. I find it comes off really easy as a big piece, as opposed to getting just the right amount of cement. And then it's a little bit difficult if there's not that much excess coming out. So I'll remove that collar from the facial, and then I'll go to the lingual once she's done curing, and then remove that collar from the back. And this works great every time for me. Again, I like to do my crown cementations one at a time. I think it's too difficult and unpredictable to try to hold all four down while you're curing them, and also a lot more difficult to clean the cement when you're doing it that way. So when we would recommend using a zirconia crown, basically anytime you do a standard SSC, a PFM, or a strip crown would be used. Again, when you're first learning these, I would avoid cases with severe crowding or severe space loss. You can still use them in those cases, but it's not something I would want to do when you're first learning your process for this. Obviously, you need to have an adequate clinical crown and ability to control hemorrhage. Definitely, you want to stick towards your cooperative patients if you're going to do this with nitrous. Otherwise, we can always have options for conscious sedation or general anesthesia. Next, we'll kind of go through the anterior express prep technique. I think this is a great tool when you're first learning how to do these. Some people might only need to do their first 2 or 3 like this. Some people might need to do their first 10. Some people might need to do their first 50 crowns like this. We all kind of learn things at different speeds. And, until you learn exactly what the prep should look like and more importantly, what the passive fit of the crown should feel like, I would probably stick to using this technique and then using these try-in crowns. Once you learn to master it, I'll kind of show you what I do now when I'm prepping these to make things a little more efficient for me and the patient. So we got 3 burrs in the kit. You got a black stripe diamond for the supragingival reduction. You got a green stripe diamond for the subgingival reduction. And you got your football diamond for the cingulum. So first you'll start with your incisal depth cuts using the base of that black stripe diamond. So 3 incisal depth cuts on the top, and that's going to be approximately about 1 millimeter. Next, you'll do your facial depth cuts using the tip of that black stripe diamond, and that's about 0.5 millimeter. Next, we're going to move on to our interproximal slices. So you'll use that black stripe diamond and do your supragingival interproximal reductions. After your interproximal slices, then you can start leveling out those depth cuts using that black stripe diamond. Don't forget to round your facial and lingual interproximal line angles. It's a spot that a lot of people tend to under reduce, is going to be those line angles. And again, we're going to do all this supragingival start. After that, you can remove your cingulum with your football. And then you can go ahead, while you still have that shoulder, you can test fit with the try-in crown. Next, go ahead and take that green stripe diamond with that, and then you're going to do a feathered edge subgingival prep, circumferentially around the whole tooth. Remove all that shoulder. Make sure you're subgingival. Don't be shy with it. You want to make sure when you're trying those crowns on later, you're feeling a complete passive fit. A lot of the times, if it feels like it's getting hung up somewhere and it won't seat. You're going to have a ledge somewhere. So go back in that shoulder, get subgingival, and just go around a few times till it goes away. Also, very critical, you want to be the long axis. You want to be parallel to the long axis of the tooth. We're not doing anything divergent, nothing convergent. Everything is going to be parallel to the long axis of the tooth. We want to stay away from that pulp. Exactly. The last thing you want to do is hit a pulp in the middle of one of these cases when you don't need to. It's a bad day for everybody. And then, yeah, then you can do one more final test fitting. Make sure you're happy with the way the crown's seating, the way it's shaped, the size, and everything like that. And again, completely passive fit. Should feel no tug or anything like that. You shouldn't feel like you're having to push anything on. It should be completely passive. If that's not the case, you can try going up one size, or maybe need to go in and reduce a little bit more. All right, now let's get to the posterior express prep. Again, same 3 burrs. First, using that football burr, reduce the buccal and lingual cusp to the depth of the central groove, maintaining cuspal inclines. And again, you use the tip of that football diamond. Again, when this is all done, I'll kind of tell you my technique for this as well. Second, you can reduce that central groove. Third, you're going to reduce the buccal and lingual occlusal thirds of the clinical crown. Then you can go ahead and switch to that supragingival black diamond and go ahead and put in your buccal and lingual depth cuts. Again, 0.5 millimeter, same as the anterior prep. Next, you can do your interproximal slices, very similar to the, interproximal slices, very similar to the anterior case. Again, leave that shoulder there to begin when you're still learning. Next, you're going to level up all these depth cuts, just like you did for the anterior case. I think a good important thing to know when you're looking down at your prep, again, the most important thing, we want the long axis of these burrs to be parallel to the long axis of the tooth. It should look just like a tree stump when you're looking down. You shouldn't see any converging or divergent walls. Just be straight down as much as possible. It's a great way to check where you are, make sure you're doing enough reduction. I'll show you a good picture here. Here's a good picture here, just seeing right down here. Follow that shoulder the whole way around. Make sure everything's uniform. Make sure you're not too thin in your reduction anywhere. And again, it should just look like a tree stump when you're looking down. Nice, straight, parallel walls to the long axis of the tooth. Go ahead and do a test fit with the try-in crown. And then just like the anterior prep, you want to go in there, remove the shoulder with your subgingival green striped diamond. Get down there, don't be shy, keep going around. You can see there where there's a little bit of a shoulder that's being left. Just go around the whole thing. Make sure you're not getting caught up anywhere. Do not leave any ledges. That way, when you do your final test fitting, it should feel very passive, very easy to fit. Should not feel like you're pushing or trying difficult to get these crowns to seat fully. So I think that those techniques are good when you're first learning how to do these. It's, if you follow those steps, you will do a correct prep every time, and you'll be able to get a crown that will fit well. Once you learn what it should look like, what those crowns should feel like when you're seating them, I think you can adapt and start to develop a process that works best for you. Personally, I only use 2 burrs now. I use a long straight diamond that's very similar to that supragingival diamond that comes in the kit. And then I'm also going to use I'll use a wheel. So I use that black diamond for my interproximal, circumferential, and subgingival cuts. And I'm using that wheel for the occlusal, the incisal, and the cingulum reductions. Just trying to minimize the time I'm having to switch burrs out, trying to keep things very efficient. The quicker I can do this for myself is better for me and better for the patient. And, any time I can save to make things more efficient is, I'm going to try to figure out the best way to do it that works for me. So this is what I like to use. Yeah, I think the most important thing, I think where a lot of people struggle with zirconia crowns is just a little lack of confidence, you know, a little hesitation to try cases they think are going to be tough. You know, this is a couple comments that I pulled off on Facebook one time, but, you know, someone was just asking about, you know, back-to-back zirconia crowns in the posterior. Are they the kind of cases you should start with? And no. But I do believe with practice, it is a technique that you can master. I really think you have to believe in yourself. You need to challenge yourself a little bit. You need to practice to improve. Don't buy a kit and just let it sit there. Actually try to utilize in your office. It's just a great aesthetic finish that parents love, patients love, and it's an option that we should all be able to offer to our patients. Confidence is key when you're doing these. Next, we'll kind of talk about case selection. I think this is a really important part, especially when you're first kind of getting into zirconia crowns. You know, so a couple things. First, set clear expectations with the parent. Have a conversation with them first. We'll talk a little bit more about that in a second. But first, you know, pulp versus no pulp. If the pulp's going to be involved due to decay, you know, ask yourself, is this really the best case to be learning on? I would recommend avoiding pulps for now while you learn the technique. I don't shy away from pulps today, but that has obviously taken some time and experience. And unless there's actually true decay that's going to the pulp, the zirconia prep will not cause a pulp exposure. I know that's a lot of thing that people worry about. The only times where the zirconia prep will cause a pulp for me is sometimes on first molars. You know, I learned my lesson one time, but always look at that pre-op film and see if it's one of those first molars that has one of those very high pulp horns. We run into those sometimes. So when that's the case, if I do see there's a very high pulp horn that is going to get exposed, I'm going to get a pulpal exposure. In those cases, I will let the parent know that that's going to be the result if we do a white crown. And I will no charge the pulpotomy if that's the case, if the parent's going to move forward with that and they're comfortable with having a pulpotomy. Zirconia versus SSCs. If I'm unsure of how the patient will do, you know, maybe they were a Frankel 3 for the exam, I'll set expectations with the parent first. I always like to let the parent know, hey, if things start to go south while we're doing treatment, are you okay if I have to switch to an SSC? Very rarely do I have a parent that says no, but I think it's a great conversation to have before everything starts, instead of while things start to go south and you're in the middle of the case. So always kind of get permission from the parent if we need to go a different route. You know, perfect example, one of our CRNA's daughters needed a couple crowns, a couple fillings. Dad was okay with SSCs. Mom was very insistent on doing zirconia crowns, which is great. We had a conversation before we started. You know, she was kind of struggling through it. Easily could have finished it on laughing gas if I was just doing SSCs. But, you know, halfway through, just let dad know, hey, I don't think it's going to happen. I don't think we can move forward. It's just going to take a little too long. And yeah, we elected to go ahead and do general anesthesia in that case. So you know, you just got to have those conversations. Best to have them before, not during the case. Let's see. I've also had the reverse. I've had parents come in. Well, I've had a dad come in who he had SSCs as a kid. So he wanted SSCs for his kid. Right as we're submitting the crown, mom calls. Mom wants a white crown. So learn my lesson there. Even if I'm doing SSCs, I'll ask the parent just to make sure, you know, everyone's going to be happy with doing a silver crown. And that dad, you know, Nick, I always make sure the dads call moms in these cases. Or vice versa. Crowding versus spacing. For now, you know, avoid cases with crowding and or cases of space loss. It can be very difficult. The good thing is, zirconia crowns are forgiving. When you start to try some of these cases with crowding, some of these cases with space loss, do know that you can reduce a crown after you've placed it and cemented it if you're trying to get a crown to fit next to it. Not always the case, but when you do have these kind of crowded cases with lots of space loss, large decay, sometimes that's what you do have to do to make the zirconias fit back to back. And then, of course, behavior management, like we said this whole time, you got to set clear expectations, discuss other techniques if needed, depending on the amount of treatment that is needed, whether that's a consultation versus general anesthesia. Just set very clear expectations. Don't set yourself up for failure, and make sure you've had those conversations if things do go south on you. But again, with time, with practice, you will get to a point where you feel just as confident offering your zirconia crown as you do with an SSC. Let's see. Okay, let's talk a little bit about order of operations. So I'll kind of talk, so for anterior cases, and this is for, obviously when we're doing stuff with laughing gas. I like to use an isolite. I think isolite makes things 10 times easier. Anyway, so we'll get the kid floating, get the tooth numb. I personally use the SOAN. We won't go too much into that, but I think that makes things a lot easier. So use the SOAN, get profound anesthesia, and we'll go ahead and get started immediately. As long as they're comfortable with the isolite end, then the first thing I'll do is I'll just test with a real fast water spray on the teeth. If the child doesn't react to that, then next step is my first step with the anterior is I'll use that wheel, and I'm going to go ahead and reduce the lingual surface of every tooth that I'm working on in the anterior. If the child doesn't react to that, things are going well. Next step, I'll go ahead and reduce the incisal of every tooth in the anterior that I'm working on. I like to start with the lingual just in case, the kid starts to shake his head, he starts pushing the isolite out, things start getting rough. Well, all I did was reduce the lingual, not a big deal. We can stop right there. And then second, of course, reducing the incisal. We're not doing that big of a reduction. Again, if things went south, you're not really leaving the kid with this like horrible aesthetic position, which the parent might not be too happy about. Once we've reduced that incisal, then I'll go ahead and I'll put that long, black, thick diamond burr on, and I'm going to go ahead and do my interproximal reductions. For the most part, once I've put that long black diamond on, I'm doing all my cuts subgingival. I'm going to go ahead and skip that supragingival reduction, skip the shoulder, all that part. And again, this is as you learn your technique. This is just the way I do it. That's worked really well for me after doing a lot of these. But again, once you do those interproximal cuts, now you're kind of committed, and you go ahead and start smoothing your surfaces, doing your circumferential reductions. I keep it simple. Lingual reduction, incisal reduction, and at that point, just remove the enamel. Once you remove the enamel and you've gone subgingival, these crowns will fit every time. Let's see. And with this, setting clear expectations. So far, I've only once ever had a case where I was only able to do D and E and had to have the kid come back to do F and G. Otherwise, I've always been able to finish it from start to finish, whether it's D, E, F, and G or E and F, etc., or a single tooth. So again, I think with this technique, with testing the water spray, reducing the lingual first, then the incisal, and just kind of feeling out the kids, seeing how they're going to respond to everything that's going on, you can you'll know when you can proceed forward and get successful results, and when you'll need to stop the case and not put yourself or the patient in a situation that's tough for everybody. Some little tips about the posterior teeth. If you're planning to do an SSC on the first molar, BILS, and you've got a zirconia crown planned on C, always do the zirconia crown first. Because if you were to do the reverse, let's say you put your SSC on the first molar and then you're going to do your zirconia crown on the canine, most likely when you go in there to do your interproximal reduction, you're going to tear up that SSC and you're going to have to take it off and start up and then re-cement a new one on. Again, like I've said a couple times now, the zirconia crowns are very forgiving. You can reduce a little bit interproximally with them and they hold up just fine. Now, another good technique too, first off, when you're first, offering these to parents and you're still learning your technique, I think a great way to go about it is just offering the white crowns to begin on just the first molars. And then maybe kind of talk to the parents about doing SSCs on the second molars. It's a great way to learn your technique. You're keeping things simple for yourself. You're not trying to do back-to-back zirconia crowns. So I would start there in your practices while you're learning your process and how you like to do things. But another tip, if you're planning to do an SSC on the E, the second molar, and a zirconia on the D, the first molar, do the zirconia first, again, for the same reason. You don't want to place your SSC on the E and then you rip up the SSC when you're prepping the zirconia crown on the D. So that's what I would recommend. And again, if you've got limited cooperation, your best cooperation is going to be at the start of the appointment. Try to do the most difficult thing first, which is going to be that zirconia crown. You don't need a lot of time to get that SSC to fit if things start to go south on you. Let's see. So here's a case. This kid was, I believe, 3 years old. We did this case on nitrous. Here's your X-ray on the left. Good size interproximal decay on E and F. We were able to avoid the pulp on this one. He's got cavities starting on the mesial of D and G. If this was a case that the parents wanted to do general anesthesia or he failed in the chair, this is a case where I probably would do 4 crowns across the front. However, this is a case that we were successful using just nitrous. So to make things easier for myself, to make it easier for this child, and to help out with the cost of things for the parents, I'm just going to slice a little bit of the enamel on D and G and just focus on putting crowns on E and F. We've had great success with this. But I'll play a video here and I'll kind of show those steps we were talking about. This whole video, the whole prep here is about 2 minutes for E and F. That's kind of what I've found, with experience from starting the prep to having the crown cemented. Once you kind of get your technique down, you can do this from start to finish about 2 minutes per tooth. But here's the prep right here.
Tell me when you're good.
Yeah, I'm good.
So
Okay, cool.
we're gonna spray some water. Kid's okay with it. Now we're gonna do that lingual reduction. And again, we're using the wheel for this. This is how I like to do it. Got my lingual reduction done. We're gonna go to the incisal now. Kid's still doing great. So we're gonna go ahead and switch spurs now. We're gonna keep moving forward. Interproximal reductions. Again, we're going subgingival from the start. Interproximal reductions are done. Now we're going to start going circumferentially. Start wherever's the most comfortable for you. Make sure you're subgingival. Don't leave any shoulders behind. Don't leave any ledges. I think he's giving us a peace sign right now, which is cool. Moving on to tooth F now. These look like these are probably size 4s on these centrals. And rounding off the size ledges, you don't necessarily have to do this step. I have a tendency to just go ahead and do it. Nice thing about this nice, thick, straight black diamond too, as long as it can fit interproximally, I know I've got the mesial distal width I need to get a crown to fit down. And that's the whole prep. So yeah, real straightforward. Works great. This is what works for me. This is what eliminates steps, makes it efficient, makes it very practical, and works great in a clinical setting. I probably do on nitrous, I probably do 3 to 5 cases, a week in the clinical setting. I'm not in the clinic very much anymore, but 3 to 5 times a week in a clinical setting. And of course, in a general anesthesia setting, we do lots of these. Let's see. And in this video, it's just kind of showing that technique of removing that cement. Simple as that. We fill that crown all the way up. I'll hold it down with finger pressure on the incisal, full cure from the front. Then I'll use the Explorer to remove that collar from the anterior. As my assistant is doing a full cure on the posterior, then I'll remove the collar from the back of that. Again, I like to do one crown at a time. I think it's easier to control hemostasis. It's easier to remove the cement. And again, I like to use just gauze pressure right before I put the crown down. That's what's worked really well for me. Let's see, I'll show. All right, this is a bit of a more difficult case. This is a case I wouldn't recommend doing as your first case. This is definitely one I did in general anesthesia, not a case I'd feel comfortable probably doing in the clinic. Probably done one similar to this, but this is quite crowded. But basically it's just showing the whole time I've been kind of talking about how these crowns can be, forgiving. So in this case, you're reducing, I got all four reduced. Things look a little tight there, especially when I'm trying on that first E. You can see with that E crown on, there's pretty much no space in between E and F, little space between D and E. But I cement that first crown. I'm going to go in there with that large black diamond, and I'm going to reduce in between both of them and then try that D on. And then, once I've got D and E cemented, again, you just keep going back in there and making yourself space. And when you have no more space to take, you kind of have to just take it from the crown after it's been cemented. So, difficult case here. Don't recommend for everyone. Is it a perfect result? No. Is it a lot better than what you had before? Is it very clinical acceptable considering the crowding? Yes, I think it looks great, but just want to demonstrate that these can be used in very crowded cases, and you can reduce these crowns after they're cemented if you need to get space from somewhere. Let's see, next case, just showing a single tooth replacement. So you can, it's nice to be able to do them when they're symmetrical. Symmetrical usually gives the best results. Sometimes if I have cases where a patient needs just a single tooth replaced, I will let the parent know, hey, it's gonna look great, but sometimes when things are asymmetrical, they don't look as good. If you'd like, I will do the crown next to it at no cost to make things symmetrical and make it look very nice. However, whether the parent wants that or doesn't want that, or you don't want to offer that, these still have really great results even when it's just a single tooth crown replacement. Let's see, I wish I could find the supernumerary pictures, but so I've had several cases with supernumeraries. So let's say you've got 6 teeth between C and H, or 5 teeth between C and H. Usually 4 of them you can get the fit really well with just the traditional upper laterals and centrals. That extra tooth, a lot of times I've had to use one of the U's, which are the lower zirconia crowns that are made for N, O, P, or Q, those lower primary molars. So that's what I'll use when I have supernumeraries to make everything fit. And then also sometimes you get, real squared lower incisors. When that's the case, I'll use the upper lateral zirconia crowns. And yeah, I think it gives a great result. Sometimes those U ones can be pretty narrow and tall. So when you have these teeth that are more short and squared, consider using those upper laterals if you need to. Next, I got a couple of different cases. So here we've got a pretty full mouth case, some posterior zirconia crowns. Another case that's, anterior and posterior, great result, crowns fit well, everything looks really nice. Great adaptation, minimal damage to the gingiva. These are all immediate post-op films. Another great case just showing, whether a tooth's been SDF treated, whether it's very large decay, it covers everything up very well. It looks great. You're gonna have very happy parents. Just a great option to offer in your practice. Another nice thing that I really hadn't touched on yet either is the great thing about the zirconia crowns is you really don't need to upsell these. When you're talking to a parent and you're giving them the option between an SSC or a zirconia crown, before you can even say white, they're going to say white. So, this is not something I sell hard. I just give the parent the option. I really let them pick what they prefer. In our office, we charge about our fee for the zirconia crowns is just about $100 more. But yeah, another great case here. And then anyways, so my biggest top 5 tricks, you know, once you've done your incisal or occlusal reductions, make sure you're removing all of the enamel. That's the simple way. If the enamel's gone, the crown's going to fit. Make sure you have a passive fit. You shouldn't be pushing anything on. You shouldn't be getting resistance. It should be very simple when you're trying it on. If you're not getting that, either you need to reduce more or you need to go up in size in the crown. Don't be shy with your occlusal reduction. I forgot to talk about, so when you're doing the posterior crowns, so, you know, for me personally, I go straight to my Wilbur, and I'm gonna go ahead and reduce. It's gonna sound like a lot, but I reduce that crown basically to the point where on the mesial and distal, you got about a millimeter and a half of tooth structure above the gingiva, which might sound like a lot, but you can do that and you don't hit the pulp, and that's worked well for every time. A lot of mistakes a lot of people make is just being a little shy without a occlusal reduction, being a little scared of getting close to the pulp. So, you know, when I first started doing these, I would get a lot of crowns where I'd get them on. I thought they were down all the way. Kid would come back. There'd be a lot of wear in the zirconia crown. And, you know, the biggest mistake I was making was just not reducing the occlusal enough. If you do get one of those cases where you got the crown cemented, it's looking a little high when you looked at the teeth next to it. Kids, you're starting to lose the kid. What I would recommend, and, you know, this is just when you're first learning, just get a burr, do a little enamelplasty on the opposing tooth, make your life a little bit easier than trying to cut off a zirconia crown and start over. Always check your occlusion. Always make sure to see what the bite looks like before I start, and want to make sure when I finish that the bite's the same. And then, of course, case selection. You know, start off with, you know, spaced. Start off with cases without pulp involved. Start with cases with good behavior. Start with cases with great spacing, no crowding. You know, if you're gonna do posterior crowns, do one on like an 8-year-old on a first molar that needs it. That's got great behavior. You got a lot of time to practice your prep. You got a lot of time to practice the fit of everything, your sizes. Good case selection is very important. But yeah, that's about it. And yeah, 750, so right in the dot. But we'll go ahead and open it for Q&A.
Yes, we are open for Q&A. By the way, thank you so much, Dr. Harney. That was amazing. So yeah, if you have any questions, there is a Q&A box. I see one from Amanda, so I'm going to view that. Let me see. Let's see. Aaron, do you see the question that's coming up?
No, I don't see any questions.
I don't either.
So, you know, the presentation will be recorded. If you look at that first slide, it's got my email on it. I encourage anyone. I'm more than happy to share tips, happy to get on the phone with anyone and talk you through any things you have questions about. So yeah, feel free to reach out if you have anything. I'm more than happy to share my experience with it.
I think I just saw one pop up. So from one doctor, it says gingival bleeding, period, comments.
Yeah. So, you know, for me personally, I've had no issues with heme just by using gauze pressure. You know, some people like to use retraction cord. Some people like to put epinephrine in the gingiva to help with bleeding. You know, some people want to use coagulant. You know, use whatever works best for you. Me personally, again, I only cement one crown at a time, and I've had no issues with gingival bleeding just holding with gauze pressure.
Okay. Another question we have is for the single crown case, was a light or extra light color crown? Was that light or extra light color crown?
That one to me looked like an extra light.
Okay. Another one we have is how do you finish and polish adjustments? So how do you finish
So
and polish? Yeah.
yeah, so personally, now, once I've learned to fit things very well, there's pretty much no adjustments or polishing needed. Sometimes with cases with the canines where if you're having to do all 4 canines, there's cases where I have had to reduce a little bit on the canine. So I always check the bite before I finish it just to make sure that's not the case. But again, the times where you need to be doing this the most is when you're first starting to do it. You didn't reduce enough on the occlusal, you seeded the crown, and you can see that it's not matching the occlusal plane with the adjacent teeth. When that's the case, I would start with an enamelplasty on the opposing tooth. And then if you need to, you can do a little bit on the crown as well. But I would start with the opposing tooth first. But that should get better as you get more comfortable with the way these are supposed to fit.
Okay. Next question. Do you use the space loss set of crowns if you originally don't have space loss and are using the space loss crowns? Am I just not reducing enough?
Yeah, so I 100%, if you're gonna get into posterior cases with crowding or space loss, like 100% make sure you have the narrow versions. The last thing you would do is get into a case where you kind of promised a white crown and then you don't have the right one to make it fit. I've never had a case where I couldn't make the crowns fit if I had a narrow one. If let's say you've got a first molar with a lot of space loss, and you're also doing a crown on the E, I would again recommend I would do the crown on the second molar first. That way, if you need to make more space, you can kind of and cement the crown on the second molar first. That way, if you need to make more space, you can remove some from the crown on E on the second molar, and you can also remove a little bit from the distal of the canine. So the zirconia crowns are, again, are very forgiving. Also, our canines, there's a good amount of enamel and dent in there. So if you got to slice a little bit to make your space to help you out when there's a lot of space loss, I've had no issues having to do that. But yeah, I think the narrow crowns are critical if you're going to tackle those harder cases in the posterior.
Another question is, do you ever reduce the interproximal of the crowns in your hand before you cement if the fit is a little tight?
Yes, yeah. Especially those cases with crowding, I've had ones where I literally can't take from anywhere else. And so I have reduced them in my hand on the mesial and the distal. And again, the good thing is I haven't had anything come back with issues with that. So again, do what you got to do to make the crowns fit. And this is rare. This is for, kids with larger teeth that are crowded, kids that are just crowded in general. So you shouldn't come across this very often, but just know that you have that available if you need it.
Okay. Another question, is the cement you use thick? Does thicker luting cement work better?
Regardless, which cement works better, I think is what works best for you. I have plenty of colleagues that like to use key tack and they like to cement, D, F, and G all at the same time. I personally don't like that. For the last 8 years, I've really only used Activa and or the Biosim. I just like the control from it. I like to hold the single tooth at a time. I used to try to do it with the key tack, and I would think I'm holding all 4 of them down, in the exact same position, and they would all set up, and then I'd bring my finger back, and then one would be off, and it'd be frustrating. So I like to have a lot of control of where that crown is going to be. So I hold it down until the curing's done on the facial and the lingual, buccal or lingual, so I prefer to use a light cured cement.
Nice. Another question, any tips for choosing size? Most common size used, start in the middle and move up or down if obviously too big or small, similar to SSC, ?
Yeah, definitely. So for the anterior teeth, your laterals usually be one size larger than the central. So with laterals, I would say, start with a 4, and then your central is probably a 3. If that 4 ends up being too big, well, then your lateral is probably a 3, and then your central is probably a 2. So the laterals are always about usually, 90% of the time your lateral is going to be one size larger than central. So that's just like a good basic rule to follow. And then for the posterior, it's, similar thing. Your first molar is usually one size larger than the posterior is what I've found. And with the posterior zirconia crown, I'd probably start with like a 5. And then, with time, you'll get real good at kind of eyeballing where you want that first starting crown to be.
Okay. Another one is, should we order white or extra white for our first kit?
I
So
think
light
it's,
or extra
I think it's
white.
just personal preference. I started off with the extra white, but over time I've kind of switched to the not so white version. I like both. I think both look really good. I think it's really just personal preference. But I will say the light ones do look a little more yellow when they're in the box, but once you actually cement them in the mouth, they look much more white. So don't be when you're looking at them in the kit, don't be discouraged by like the little yellow tint to them.
From a sales standpoint, we definitely sell more of the light. I say the extra light ones are kind of like flippers. Like if you want that extra white, like pageant look, then like the extra light is good. And the light I think is a little more natural, but I think so we definitely sell more of the light.
Yeah, I would agree. I prefer the light over time.
Okay, and then we're gonna do the last question here because it's almost 8. I have had 2 cases out of many where I did zirconia plus pulpotomy on a first primary molar, high pulp horn, but caries nowhere near the pulp,
Yep.
and had them obsessed. Have you ever had this happen? Do you ever worry about invading biological width and that possible contributing to the, I don't know this word, aforementioned concern?
Aforementioned
Thank you.
concern. Yeah.
Thank you.
Yeah. So, personally, I don't think my success rate matters whether I've done an SSC or zirconia when I'm doing a pulpotomy. I think a lot of it has been more related to like pulpotomy technique. So personally, I think whether you choose an SSC or zirconia on those first molar cases with a high pulp horn, and you're going to be doing a pulp, I don't think it changes the outcome whether you do a white crown or a silver crown. That's my personal opinion. And just kind of observing over time in our office ones that have failed. So I feel comfortable regardless. But yeah, that's just the way I feel. I personally use MTA for our pulps, and we've had great success for sure.